papillosquamous disorder, we are going to learn about the papules, we are going to learn about the plaques, we are going to learn about the squamous, means you will be having scaling, right? So we will discuss about the papillosquamous disorder. Okay, the first one we have got is psoriasis. Psoriasis is going to be a autoimmune kind of disorder, beta. It is a T cell mediated disorder where you will be having psoriasis, you will be having lichen planus and pityriasis rosea. ये तीन disorder हमको इसमें पढ़ने. Three things we are going to see over here in this particular chapter. Three things we are going to discuss. First disease is psoriasis. Second is going to be lichen planus. Third one is going to be rosea, pityriasis rosea, है ना. तो पेपुलो का मतलब तो हो गया प्लाग या प्लैक, पेप्यूल्स विल बी देयर. स्क्वामस का मतलब हो गया स्केलिंग विल बी देयर. So remember here also we are going to find what? Scaling. What is the most common site for this psoriasis? Beta, psoriasis is going to be, most common site is going to be extensor surface, है ना. ये मोस्ट कॉमन साइट क्या होता है इसका? बाहर वाली सरफेस पे होगा, एक्सटेंसर सरफेस पे होगा. Most common type of psoriasis is going to be psoriasis vulgaris, beta. Psoriasis vulgaris is the most common type of psoriasis. What are the things you will be finding? This is going to be your polish is the mnemonic. P for pitting will be there. O for oil drop sign will be there. L for OL together. This is going to be what? Oil drop sign. Okay. This is going to be onycholysis will be there. I for irregular pitting will be there, and as such is going to be in the favor of subungual hyperkeratosis. क्या क्या मिलेगा psoriasis में? First thing you will be having is going to be beta pitting. Pitting is going to be there. What kind of pitting is this? This is going to be regular, irregular, deep or superficial. Okay, so this is going to be deep pitting. Regular hoga, irregular hoga. This is a irregular disease. You will be having irregular pitting, right? So you will be having deep irregular pitting will be there. What else you will be having? You will be having a loss of this nail. This is known as onycholysis. This is known as onycholysis will be there. You will be having this patch like structure. This patch is known as which patch? This patch is known as Salmon patch. Yes. And turnover time is going to change to 4 to 8 days, beta, है ना? 4 to 8 days. Worn off ring will be there. This is going to be the worn off ring. When you try to remove this worn off ring, okay, so you will be having a membrane around it. This membrane is known as what? Berkeley's membrane. Around it there will be a membrane over it. This is known as Berkeley's membrane. And when you try to remove this Berkeley's membrane, what is going to happen? You will be having pinpoint bleeding will be there. When you try to remove this membrane, you will be having appearance of pinpoint bleeding, and this particular test is known as what? This test is known as Grattas test, and this sign is known as pinpoint bleeding sign is known as what? Auspitz sign. Very very important, your previous year exam question. Okay, so what is going to be there? You will be having this worn off ring halo around this particular thing, around the lesion. You will be having this type of halo. They have asked this question about the Salmon patch, right? They have asked a question about the Salmon patch. They have asked a question on the Berkeley's membrane. When you try to peel off this Berkeley's membrane, when you try to remove this Berkeley's membrane, what is going to happen? There will be appearance of this pinpoint bleeding, and this pinpoint bleeding appearance is known as which sign? This is known as Auspitz sign, and this test is known as which test? This test is known as Grattas test. Very very important. All these things are important questions that has been asked. They have asked a question from dermatology about subungual hyperkeratosis. They have asked a image based question on this particular Salmon patch. They have asked a question on this Grattas test, Auspitz signs, right? They have asked questions on pitting also, right? All these things are very very important, and important keywords. Then we have discussed about this histopathological slides. If you can understand this histopathological slides, very very good, right? So what is going to happen? We will be having epidermis, we will be having dermoepidermal junction, and then you will be having dermis, right? This part of epidermis which is trying to invaginate into dermis is known as what, beta? इस part को क्या बोलते हैं हम लोग? The part of epidermis which is trying to invaginate into dermis, this is known as rete-ridges. This is known as rete-ridges. Whereas the part of dermis which is trying to go into epidermis, this is known as dermal papilla, beta. This is known as dermal papilla. So we have got rete-ridges, we have got dermal papilla, right? So this is going to be the first thing. Can you appreciate? You will be having what? Elongated rete-ridges will be there. Elongated rete-ridges will be there, or there will be very deep rete-ridges will be there. First thing. Second thing you can appreciate over here, this is going to be what? This is going to be the pustules that you can appreciate. This is going to be known as what? Kogos pustule. This, oh sorry, spongiform pustules of Kogos. These are your Kogos pustules, right? This is accumulation of abscess over here. This is known as which abscess? This is known as Munro's microabscess. Okay, you will be having appearance of this nucleus in the stratum corneum. You can appreciate the nucleus in the stratum corneum. This is known as parakeratosis. All these things are going to be the features, है ना? ये सारे किसके फीचर्स है बेटा? सोरियासिस के. सोरियासिस विल बी हैविंग व्हाट? पैराकेरेटोसिस, मतलब प्रेजेंस ऑफ न्यूक्लियस विल बी देयर. और क्या मिलेगा सोरियासिस आइडेंटिफाई करने के लिए? यू विल बी हैविंग कोगोज पस्ट्यूल. यू विल बी हैविंग कोगोज पस्ट्यूल. You will be having Munro microabscess. You will be having what? Munro's microabscess, Kogos pustules. Okay, you will be having elongated rete ridges will be there. And you will be having what? Hyperkeratosis. You will be having increased in the deposition of keratin. Right, these are the things. This is how we are going to make the diagnosis of this particular thing. Anything out of them you will be finding in the question, you will be marking it as what? This is a question from the psoriasis, right? And then we have got what? Then we have got different types of psoriasis. We have got scalp psoriasis, where you will be having the silver white scaling on the scalp. We have got this pustular psoriasis. If you are having scales along with the pus, this is known as pustular psoriasis. And in fact, the drug of choice for this pustular psoriasis is going to be what, beta? This is going to be acetretin, which is going to work for 3 years. है ना? इसका side effect कब तक रहेगा? It is going to be teratogenic for 3 years. Acetretin, right? Then we have got this gutta-like structures that you can appreciate. This is going to be what? Guttate psoriasis. After a upper respiratory tract infection, if patient is having this type of psoriasis, this is known as guttate psoriasis. Treatment is going to be what, beta? You need to give what? Antibiotic to the patient. Then we have got psoriasis on a flexural surface. This is going to be what? This is going to be your inverse psoriasis. Drug of choice for inverse psoriasis is what? Methotrexate. Methotrexate is the drug of choice here. Then we have got what? Erythrodermic psoriasis, red color psoriasis or erythrodermic psoriasis. Drug of choice is going to be what, beta? Again methotrexate. Erythema का मतलब ही क्या होता है? Red. So you will be having redness on the skin, and psoriasis will be there. The drug of choice will be what? Methotrexate, beta. Methotrexate. And lastly, we have got what? Impetigo herpetiformis. Impetigo herpetiformis is a psoriasis in pregnancy. What is the thing that you can use over here? You can give steroids, you can give cyclosporin. Can you give methotrexate? No, it is going to be teratogenic. It is going to kill the fetus here, right? तो methotrexate यहाँ पर नहीं देना, right? It is going to be anti-cancer drug which is going to kill the any cell which is going to be dividing rapidly, right? And fetus is something which is going to divide rapidly, so that can be dead. In fact, in the cases of in certain cases you are definitely using what? You are using this drugs, है ना? कई जगह तो आप इसको काम में ही लेते हो, मोल वगैरह डिलीट करने के लिए you are using this thing, right? So we have discussed about this thing by so far. Now what is the pathogenesis of this particular one, right? Pathogenesis is going to have what? Chronic inflammation due to T cells will be there. Epidermis में क्या मिलेगा बेटा? Psoriasis में you will be having hyperkeratosis. That is why you are having what? You are having on the nails you will be having what? You will be having accumulation of what? This particular keratin deposition will be there. Epidermal transit time will be decreased to 4 to 8 days. That is going to be 4 to 8 days will be their epidermal transit time. Associated with certain genes, what are the things we are having? HLA-CW6 and HLA-B27. B27 has got lots of other associations also, but this CW6 is going to be here for the psoriasis, right? We can have psoriatic arthritis, and this psoriatic arthritis is going to show you penicillin cup deformity and Sosa's digit. Very, very important radiological and orthopedics finding that penicillin cup deformity you will be having, and you will also have this Sosa's digit, right? In dermis you will be having inflammation, and you will be having activation of T helper 1 and T helper 17 cells. right? Other system association is going to be what? You will be having this particular disease associated with the atherosclerosis. This is associated with the atherosclerosis and certain metabolic syndromes also. Treatment क्या करोगे? In the beginning phase you will like to use what? Scaling is there, so you want to remove the scaling, you can give what? Moisturizers, you can use steroids, you can use coal tar in this particular patient in the beginning. You can also give phototherapy to this particular patient. Phototherapy, narrow banded UVA phototherapy. You can give Soralin UVA phototherapy. Soralin is working as a photosensitizer, right? You can also use methotrexate, which is a DHFR reductase inhibitor, right? You can give it for plaque psoriasis, pustular psoriasis, and erythrodermic psoriasis. Can anyone tell me where else do we use this methotrexate? Methotrexate और कौन सी डिजीज में आप लोग यूज में लेते हो commonly in the orthopedics, right? We can use cyclosporin as steroids if it is causing this particular thing in the pregnancy. This is going to be, we can also use calcineurin inhibitors, right? Acitretin is the drug of choice for pustular psoriasis. If less than 10% body surface area is covered, how we will assess? If 10% or less than 10% body area is covered, we can give the steroids to the patient, we can give tazarotene, we can give emollients or like lotions we can give to the patient, emollients. अगर 10% से ज़्यादा body surface area covered है, we can give what? PUA, we can give systemic drugs to the patient, we can use systemic drugs to the patient. Interleukin 17 inhibitor, this is going to be secukinumab, we can use secukinumab. PD4 inhibitors like apremilast and TNF alpha blocker like acute girl, adalimumab, certolizumab, ustekinumab, right? These are the drugs you can use, etanercept and golimumab. These are the acute girl. This is going to be what? TNF alpha blockers, right? So we can use any of them. This is about the psoriasis. Definite one question they will be asking you about psoriasis, important one, right? Second thing we are going to discuss about the lichen planus beta. Lichen planus is going to be a very chronic immune disease. This disease is also known as what? 6P disease. इस disease का दूसरा नाम क्या है? 6P disease. Why we call it 6P? Because you will be having 6 P's. What are those 6 P's that we are having? You will be having plain, you will be having purple, polygonal, pruritic, papules will be there, and these are going to be associated with the pterygium. So sometimes we call it 6P or 5P disease also. Very good. In rheumatoid arthritis we can use what? Methotrexate, है ना? Methotrexate rheumatoid arthritis में देना है, उसके साथ में फॉलिक एसिड भी देना है. लेकिन जिस दिन आप methotrexate देते हो, the day you are giving methotrexate, we are avoiding what? Folic acid, है ना? It's not necessary, but yes, in certain literatures we are doing that, so we do that. Like for example, we need to give it weekly. तो मंडे को अगर यू आर गोइंग टू गिव दिस methotrexate टू द पेशेंट, तो मंडे को आप क्या करोगे? फॉलिक एसिड नहीं दोगे साथ में. रेस्ट 6 days you can give folic acid to the patient, right? So these are going to be your plain purple polygonal pruritic papules beta. These papules you can appreciate over here. Can you appreciate? These are the lesions we are having. They are going to be plain topped, है ना? ये जो lesions हैं, these are the plain topped lesions. They are polygonal. They are going to be pruritic. They are going to be purple, and you can also appreciate here you will be having what? Pterygium. You can have the pterygium where the lateral where the proximal nail fold is going to divide the nail into 2 halves. दो भाग में विभाजित करेगा, दो भाग में डिवाइड करेगा. It is going to divide it, this particular thing, into 2 halves. This is going to be pterygium. Okay, along with that you will also have this type of white reticular lacy pattern on the mouth, on the mucosa involvement will be there. This is going to be very characteristic of what? Wickham's triad. This is known as what? Wickham's triad. This is known as what, beta? Wickham's triad, right? What are the triggers? Remember these 2 triggers you have to remember. They have got association. Hepatitis C, which is the most chronic type of hepatitis that we are having, which can cause hepatocellular carcinoma also, which can cause cirrhosis also in the patient, right? And second thing we have got is dental amalgam can also cause this particular thing, right? Dental amalgam and hepatitis C. Then on the histopathological examination, you will be finding what? You will be finding seaweed bodies, Max Joseph cleft space, hypergranulosis, and remember here the red ridges are going to be what? These red ridges are going to be sawtooth in appearance, right? So you will be having this sawtooth red ridges. कैसी red ridges होगी बेटा यहाँ पर? Sawtooth red ridges will be there, right? You will be having Max Joseph cleft space. You will be having what? Seaweed bodies. You will be having seaweed bodies. You will be having Max Joseph cleft space. This space is known as Max Joseph cleft space. You will be having seaweed bodies. You will be having hypergranulosis, है ना? वहाँ क्या था? हाइपरकेरेटोसिस. ऊपर क्या पड़ा था? हाइपरकेरेटोसिस. यहाँ कौन सी लेयर बढ़ जाएगी? हाइपरग्रेनुलोसिस, है ना? Granulosis will be there. We can also have one disease on the hairs. You can have lichen planopilaris, which is a scarring type of alopecia. हम लोगों ने पढ़ा था वहाँ पर lichen planopilaris, which is a scarring type of alopecia, beta, right? It is going to show you one phenomena. That phenomena is known as isomorphic phenomena. क्या बोलते हैं उस phenomena को? Isomorphic phenomena. Iso means same, morphic means morphology. So whenever you have a lesion, the same morphology lesion will be beginning over here, right? So what is going to happen? For example, if I am going to have some trauma over here and I am a psoriasis patient, what is going to happen? At the site of the trauma, I will also have the psoriasis. So this is known as isomorphic phenomena. It is seen with the psoriasis, it is seen with the lichen planus, it is seen with the vulgaris, it is seen with the vitiligo, not vulgaris. It is also seen with the vitiligo, beta, vitiligo. Right, so this is going to be seen with the vitiligo, lichen planus, and psoriasis. Whereas this pseudo cobnerization or false cobnerization that you will be finding this thing in the molluscum contagiosum. Molluscum means soft, contagiosum means highly infectious nodules will be there. Pearly white umbilicated nodules will be there on the skin, which is due to immunodeficiency state, and these lesions are going to spread by touching, right? So what is going to happen? You are going to touch your lesion, and now you are touching it over here. What is going to happen? This molluscum contagiosum will come over here, right? And this thing is going to another person also. So we have got two types of phenomena. One is known as isomorphic phenomena. This isomorphic phenomena is characteristic of what? This is characteristic of what? These lesions. Psoriasis, lichen planus, and vitiligo. They will be showing what? Isomorphic phenomena. Whereas this pseudo cobnerization, false isocobner phenomena, false isomorphic phenomena, this isomorphic is also known as Kobner phenomena. So false Kobner phenomena is seen with molluscum contagiosum, बेटा, है ना? False Kobner कहाँ मिलेगा? Molluscum contagiosum में मिलेगा. और warty lesions, कोई भी wart वाला infection हो, virus वाला infection हो, वहाँ मिलेगा. Then we have got a special term. This is known as lichen nitidus. This lichen nitidus, beta, this lichen nitidus will be having what? Also known as mini lichen, where you will be having tiny skin colored bumps will be there. Skin colored bumps over the extensor surface. कौन सी surface पे होगा बेटा ये? Extensor surface पे elbow में tiny colored skin colored bumping will be there. On histopathological identification, this is very important. You will be finding this sign. You will be finding this sign. This sign is known as what? Ball in claw appearance. This sign is known as ball in claw appearance. Okay, ball in claw appearance. This sign is known as ball in claw appearance. Ball in claw appearance will be there, right? Treatment will be, it is going to be self-resolving thing. You can apply topical steroids over here. Topical steroids आप यहाँ पर दे सकते हो, but generally it is going to be a self-resolving thing. Lastly, this this disorder that we are having is going to be your pityriasis versicolor. Pityriasis rosea. Versicolor we have already seen, right? Versicolor is going to be another one. This is your pityriasis rosea, where you will be having this red color patch, beta, na? Red color ka patch hoga on the back, on the trunk, and this patch will be radiating all the way like in a Christmas tree pattern, है ना? What is going to be the pattern beta here? This is going to be a Christmas tree pattern. So you will be having the first patch. This first patch is also known as mother patch. This first patch is also known as herald patch. And generally this thing is going to be asymptomatic. It is going to be acute disease. Most common trigger is going to be HHV7, important, human herpes virus 7, which is also known as 6/7, is going to cause what? Xanthum subitum, and also cause roseola infantum, right? You will be having this red color plaque present on the trunk. First patch is known as mother patch, also known as herald patch, and then you will be having this Christmas tree appearance will be there. When you are going to see the scales of this particular person, you are going to see the scales, you will be finding collarate of scale, collar like scaling will be there, collar like scaling. You will be having cigarette paper like scaling, collar like scaling, cigarette paper like scaling. You will be having a sign, this is known as hanging curtain sign will be positive. Which sign will be there? Hanging curtain sign will be positive. Generally it is a self-resolving condition. You apply emollients, you apply steroids, and it will be fine, right? So this is pretty much about the pityriasis rosea, right? So we have learned about three important things in papilloscomus disorder. This is going to be psoriasis, this is going to be lichen planus, and this is going to be what? This is going to be rosea, right? Next thing we are going to discuss is about the infections. So we have got bacterial infections. What are the bacterial infections we have got? कौन से bacterial infection होते हैं? These are going to be your pyodermas. We can have skin infections. So we can get skin infections on the basis of location only, right? So location के हिसाब से एक बार देख लेते हैं. So superficially we have got what? Impetigo. It can be bullous impetigo, it can be non-bullous impetigo. Bullous impetigo will be having bulla formation, that is going to be due to staph most commonly. Second is non-bullous impetigo, that is due to what? That is due to strepto beta, strepto की वजह से होगा ना. Non-bullous impetigo, honey colored crusting. So we have discussed about the impetigo. Then we will discuss about certain types of ecthyma. We have got multiple types of ecthyma beta. Then we will discuss about the erysipelas. Then we will discuss about the cellulitis. Remember, this cellulitis will go deep into the subcutaneous tissue. ये cellulitis यहाँ तक आ जाएगा, नीचे तक subcutaneous tissue, right? Then we can have deep fascias, you can have muscles, so you can have necrotizing fasciitis, and this necrotizing fasciitis can be due to staph also, है ना? ये staph की वजह से भी हो सकता है. And you can also have this infection like deep infections. This is due to clostridium also can cause this, right? You can have osteomyelitis. The king for osteomyelitis is what? This is nothing but your staph aureus, right? It can go to the bones, right? Staph aureus is the king, right? So we have got this bacterial, viral, fungal, parasitic skin infections. We are having epidermis tak. You can have dermis, you can have subcutaneous, you can have deep fascia, muscle, you can have bones, and you can have this artery vessels and nerves, right? You can have this necrotizing fasciitis till this particular part. So let's try to understand what is folliculitis, what is bacterial infections, like what is folliculitis, what is furuncle, what is carbuncle, है ना? तीनों चीजें देख लेते हैं. Folliculitis, furuncle and carbuncle. You can appreciate there will be loss of single follicle is involved. If there is inflammation of a single hair follicle, it can be papillar, it can be pustular, है ना? इसको बोलते हैं folliculitis. It can happen generally around the face also. Papillar, it can be pustular. Pus भी हो सकता है, it can be normally papillar also. This is known as what? Folliculitis. Here remember, single hair follicle is involved. Single hair follicle is involved. This is known as folliculitis, right? Second thing is going to be your furuncle. Furuncle में क्या होगा? Folliculitis तो हो गई, साथ में there will be involvement of a follicle. Along with that, you will be having parafollicular area will be involved. You can appreciate this is going to be what? Single follicle is involved. Along with that, parafollicular area is going to get involved. This is going to be what? This is known as furuncle. ये ऐसा दिखेगा. Parafollicular area is going to get involved, right? And then you have got what? Then you have got carbuncle, and this carbuncle, multiple follicles are going to get involved, like in generally happening in the nape of the neck, and those patients who are diabetes mellitus associated disease, right? Associated with diabetes mellitus. So this is going to be what beta? This is going to be carbuncle, right? Due to carbuncle you can have, right? Then we have got what? Then we have got another infection. This is known as erythrasma. So basic समझ में आया what is folliculitis, what is furuncle, what is carbuncle, right? Then we have got another infection, beta. Another infection is going to be what? Erythrasma. Another infection we have got is erythrasma. Erythrasma is due to Corynebacterium minutissimum. Corynebacterium diphtheria is going to cause what? Diphtheria. Corynebacterium minutissimum we have discussed in micro also. This is going to cause what? Erythrasma. And this erythrasma is due to what? It is due to this color that you are appearing, that color that is coming, that is going to give you on wood lamp examination. It is going to give you coral red fluorescence. And why this coral red fluorescence? It is due to corpoporphyrin 3. Corpoporphyrin 3 is going to be responsible for this coral red fluorescence, right? This is the wood lamp exam that we have been talking about, right? Here you will be having this reddish brown color pigmentation that you can appreciate. This is going to be erythrasma. What is ecthyma? We can have ecthyma pyogenicum, we can have ecthyma gangrenosum, right? We can have ecthyma contagiosum. Pyogenicum is going to be with the pyogenes beta, streptococcus pyogenes, right? Gangrenosum is due to pseudomonas, which is a nasty bacteria we have got, right? And parapox virus is going to cause what? Ecthyma contagiosum, ecthyma contagiosum, right? We have got impetigo. Impetigo can be two types of impetigo. We can have bullous impetigo. Bulla will be there. That is a fluid filled cavity, clear viscous, clear fluid filled cavity, that is known as bulla, more than 1 centimeter. So we can have this type of infection. This is bullous impetigo. We can have non-bullous impetigo, where you will be having this dried up exudate, right? This dried up exudate is known as what? Honey colored crusting. You will be having what? Honey colored crusting. This is known as dried up exudate, right? These are your superficial bacterial infection. Remember, this is going to be caused, non-bullous is due to streptococcus followed by staph, whereas here you will be having what? Staph followed by strepto. So this is going to be the opposite thing. Here you will be having epidermolytic toxin leading to what? Bulla formation, and treatment will be mupirocin. For cellulitis versus erysipelas, remember both of them appear similar from outside, but this cellulitis is going to be deeper thing. It is going to invade till your subcutaneous, right? Whereas this erysipelas is going to be what? Superficial infection. It is going to be superficial skin infection with a demarcated margin. Here the margins are not going to be demarcated, right? This is going to deeply invade the lesion till hypodermis. This is a superficial lesion. Okay, it is generally happening because of group A beta hemolytic streptococci, right? This is cellulitis. Most common cause is going to be what? Staph aureus. Staph is the most common cause for this cellulitis, and the treatment is going to be what? Amoxicillin, right? This is what we are using in this particular case, right? Here you will be having group A beta hemolytic streptococci. In this particular case, it is going to be superficial, and treatment will be what? Again, you can use the same group of drugs also, right? Then we have got what? SSSS. What is staphylococcal skin scalded syndrome? It is due to staph aureus. Staph means grape like clusters, aureus means golden yellow color. Okay, gold will be AU, right? So you will be having ETA, ETB toxin making antibodies against what? Desmoglein, making this damage against desmoglein. And this desmoglein is responsible for the connection of two keratinocyte. अगर यहाँ पर एंटीबॉडी बन गया, कुछ भी आ गया, टॉक्सिन आ गया, क्या होगा? टूट जाएगा. अगर ये टूट जाएगा तो क्या बॉडी में स्किन स्काल्डिंग होना स्टार्ट हो जाएगी? यस, दैट इज व्हाई वी आर हैविंग स्टेफाइलोकोकल स्किन स्काल्डेड syndrome. We can also have Stevens-Johnson syndrome. We can also have toxic epidermolysis necrosis, TEN and SJS. Right? They are going to affect what? Skin and mucosa also. SJS, we call it if it is covering less than 10% of body surface area. If it is covering more than 30% of the body surface area, this is considered as what? 10. Overlap is between 10 to 29 is going to be overlap syndrome. Remember, in anthrax also you will be having cutaneous anthrax. Those people who are carrying the dead animal, they will be having black color malignant pustule. Malignant means it is not cancerous. It is going to be known as what? Hyde-Porter's disease, where you will be having this black color scar will be there, right? Another patient you will be having a scrub typhus patient, where you will be having black color scar will be there. Along with that, you will at the site you will be having, along with that you will be having erythema, fever, lymphadenopathy, all this malaise, all these things will be there, right? It is going to be a Laus bone disease, tick bone disease, mite bone disease. So your answer will be Laus flea, tick tick, mite. Remember, we remembered the mite. So it is going to be a mite bone disease. You will be having Orencia sushugamushi, right? And the larva is known as shigerosis, right? And the drug of choice is going to be what? Doxycycline for all of these particular cases. For the pyoderma skin infection, the treatment will be, you can apply what? Fusidic acid over here, or you can also apply mupirocin ointment, right? This is the basic thing we are having. Then we will discuss about the fungal infection. The first fungal infection, very important, is going to be what, beta? This is going to be your pityriasis versicolor. Pityriasis means scaling and versicolor mean different color. Versicolor matlab different color. So you will be having different color matlab hypo and hyperpigmentation will be there. Hypo and hyperpigmentation will be there. And this is due to which acid? This is due to azelaic acid, beta. कौन सा एसिड की वजह से होगा? एजेलिक एसिड की वजह से होगा. इंक्रीज इन मेलानोसोम्स विल बी देयर लीडिंग टू व्हाट? हाइपर पिगमेंटेशन. Azelaic acid is going to cause what? Hypopigmentation. Color discoloration will be there. Azelaic acid. Causative agent is going to be the previous year question, Malassezia furfur and Malassezia globosa. Furfur and globosa are the causative agent we have got. And fine brany scales, you will be finding fine brany scales. On microscopy, you are going to find this type of appearance on a, you can call it like KOH mount. You will be making, you will be finding spaghetti and meatball appearance, also known as banana and grapes appearance. Very important entity. Spaghetti, meatball, banana and grapes appearance, right? On wood lamp examination, yellow orange color will be there. Treatment is going to be what? Selenium sulfide. When you are going to put the same thing on SDA beta, when you are going to put the same thing on Sebro dextrose agar, what is going to happen? It is going to give you fried egg colonies. Fried egg colonies. But remember, you need to put what? Olive oil. Then you will be getting what? Fried egg colonies will be there. Next one we have got is the pedra, which is a superficial hair nodule infection that we are having, right? We can have black pedra. This is due to forte. We can have white pedra. This is due to bijli. So white pedra is due to bijli. Black pedra is due to forte. Pedra forte is going to cause what? Black pedra. And bijli is going to cause what? This is going to cause what? White pedra. Bijli is going to be light. Light is going to be white. Treatment will be azoles. The ultimate treatment is going to be what? Shave the head. So this is something you will be finding in those Baba. You know Baba, those people who are having long hairs, है ना? तो उन लोगों में क्या होता है? This pedra infection is going to be common. Then we have got dermatophytes, which are going to be superficial skin infections that we have got, right? These are the skin infection which are going to be what? They are going to be erythematous, means they will be red, they will be pruritic, and they will be having annular plaque. Annular plaque will be there, right? So they will be having active margins and they will be having central clearing. These are going to be your dermatophyte infections. So first one we have got is trichophytone. This is going to be involving all three structures: hairs, nails and skin, right? Epidermophytone is not going to infect what? Hairs. E के बाद में H आता है, it is not going to infect hairs, right? It is going to infect nails and skin. M के बाद में N आता है, it is not going to infect the nails, it is going to infect the hairs and skin. So they are skipping their पड़ोसीज, है ना? इनके पड़ोसियों को छोड़ रहे हैं, बाकी सबको इन्फेक्ट कर रहे हैं, right? So we have got two types of tinea capitis beta. We have got tinea capitis, which is scarring type, which is non-scarring type. Scarring type of alopecia is seen with the painful boggy swelling. If you find in any question, you will be marking your answer as Kirion. It is due to tinea mentagrophyte. It is due to tinea verrucosum beta. Tinea verrucosum, tinea mentagrophyte. Whereas if you are finding dense crusting, you are finding scutula, favus, and this is an endemic thing. This is the endemic thing which is you will be finding in the Kashmiri people. This thing you will be finding in the Kashmiri people. This is due to tinea snoleni. Tinea snoleni is going to be there, right? Tinea snoleni is going to be there. Whereas you will be having this black dot and gray patch. These are going to be what? These are due to tinea volutium, and these are going to be endothrix and ectotrix kind of infections. They are non-scarring type of alopecia. मतलब अगर ऐसा कुछ होता है, you will be completely fine after that. You will be having all the hairs regain will be there, right? Then we have got what? Tinea cruris, tinea pedis. Remember the drug of choice for these tinea capitis is going to be what? This is going to be griseofulvin. Next thing we have got is tinea cruris and tinea pedis. Can you appreciate? This is a lesion which is going to have what? Central clearing, right? So this is an annular lesion with a active margin, beta active margin. Tinea cruris is going to be there. This is also known as Dobby itch. It is something that you will be finding in the groin area. Why? Because of lots of moisture, lots of water. Fungus just loves the moisture, it loves the water. Wherever you give water to the fungus, it will be there, right? In rainy seasons, you will be having lots and lots of fungal infections, right? Tinea corporis means it is going to be tinea on the body. Tinea pedis means it is a tinea means superficial fungal infection on the, pedis means on the foot. In the athlete, it is also seen because they are wearing socks for all the time and they are running, because of that sweating will be there. So this is going to cause what? Athlete foot. Central scarring is a feature of TB, whereas central clearing is a feature of tinea. Lupus vulgaris is the most common type of skin TB, right? Central crusting is a feature of leishmania, beta, leishmania. And central crusting is a feature of leishmania. Which leishmania? Leishmania tropica, also known as oriental sore, Baghdad boil, Delhi boil, Aleppo boil we have discussed, right? Tinea capitis, drug of choice is griseofulvin. Tinea incognito is going to be because of steroid use. 10% QH mount pay, you will be finding those refractile hyphae. Drug of choice is going to be what? Terbinafine or cycloperoxamine, amorolafine. These are going to be the nail liquor that we are having that you can apply on the tinea pedis also. Then we have got what? Candida infection. This candida is going to be what? Candida albicans. We can have oral candidiasis, we can have vaginal candidiasis, we can have esophageal candidiasis, candida intertrigo. Okay, so we have got multiple types of candidiasis. This oral candidiasis is going to have what? Pseudomembrane. This is going to have pseudomembrane, also known as oral thrush. Esophageal candidiasis will be having what? What is the drug that you would like to use? Is going to be what? Fluconazole. Esophageal candidiasis is only going to happen in which patient? Which are neutropenic patient, immunocompromised patient. Intertrigo is going to happening on the intertriginous areas where you will be having plaques, you will be having what? Satellite lesions will be there. Balanoposthitis will be having radial fissuring of the skin will be there around the prepuce. This is generally seen in the diabetes mellitus patient. And vaginal candidiasis is going to have what? Beta, you will be having pruritus. Thick white cuddy discharge will be coming along with the pruritus, and on SDA you will be finding creamy pasty color colonies. Okay, KH mount is going to show you budding yeast cells with pseudo hyphae, and one phenomena that you can appreciate is known as Raynaud-Broad phenomena, also known as germ tube formation, right? You can also use which agar? Chrome agar for the identification of multiple species, different species identification. You can use what? You can use the chrome agar. This is going to be the chrome agar. The treatment is going to be what? Fluconazole. You can use clotrimazole. You can use nystatin C, right? Then we have got what? Then we have got chromoblastomycosis. Then we have got what? Chromoblastomycosis, beta. Sorry, sporotrichosis first. Let's talk about the sporotrichosis. Sporotrichosis is due to Sporothrix-Schenke. This is also known as Rose Gardner's disease. This is also known as Valentine disease. Rose Gardner disease. Here you will be having this nodulo-ulcerative lesion. And this lesion will be having what? Lymphocutaneous spread will be there. What kind of spread will be there? Lymphocutaneous spread will be there. On histopathological, you will find the asteroid body. What are these asteroid bodies? These are the yeast cells surrounded by pink eosinophilic material. This is just a yeast cell which is surrounded by pink eosinophilic material. This is known as what? This is known as asteroid body. Central basophilic yeast with pink eosinophilic material. This is going to be what? Asteroid body, right? Treatment will be antifungal you would like to use, and you can also give what? Itraconazole to the patient. You can give itraconazole to the patient. Then we have got mycetoma. Mycetoma is a disease you will be finding in the farmers, right? Normally you will be having a discharging sinus will be there. We can get two types of mycetoma, eumycetoma and actinomycetoma. Actinomycetoma is going to be what beta? It is going to be a bacterial one. A के बाद में B आता है, after A there will be B, and after E there will be F, so it is going to be a fungal one. It is going to be a fungal one. It is due to actinomadurai. It is due to nocardia. Okay, and here you will be having black color granules. Here you will be having white or two yellow color granules will be there. Treatment, here you will be giving antibiotics. This is going to be antifungal, but still they are not working. You need to go for amputation definitely. Okay, we need to do what? Amputation. What is the regimen that we are following? That is known as Welsh regimen, which is going to take care of both the things by giving amikacin plus cotrimoxazole, which is a combination of trimethoprim plus sulfamethoxazole given in 1:5 concentration, will convert into 1:20 concentration in blood. Right, this is going to be what? Cotrimoxazole, combination of trimethoprim plus sulfamethoxazole. Right. Then we have got some parasitic infections. Two important parasitic infections are going to be there. One is going to be scabies beta. Scabies is going to be happening in the circle of Abra. This is the circle of Abra where you will be having most of the infections, right? This is also known as Prince itch disease. This is also known as 7-year itch disease, right? It is going to happen in the family. You will be having, this is known as circle of Abra, is the most common site. Okay, you can have the Sarcoptes scabies, which is a mite which is responsible for this particular disease, and most characteristic lesion that you will be finding are known as burrows, which are going to be present on the stratum corneum beta. Stratum corneum will be having the burrows, right? You can have crusted scabies. This is the Norwegian scabies. This is due to taking of the steroid. This thing can happen, right? This is the worst prognosis beta, and the treatment will be, you can give ivermectin here. Ivermectin you will also use in the onchocerca volvulus in the strongyloid stercoralis, right? There are very few indication of this ivermectin. Two important one I'm telling you, strongyloid stercoralis and onchocerca volvulus, right? Then we have got this burrows. These are the burrows in the stratum corneum, and this particular patient will be having itching. Not just this patient will be having itching. This is known as Prince itch disease. This disease will also spread in the family. All the family will be having the itches. What itching will be there? What we need to do? We need to apply 5% of permethrin to the patient. Below the neck, you will be applying the permethrin in the circle of Abra, right? In the circle of Abra, you will be applying this permethrin, and then you need to put all the clothes into hot water, not just you, all the family. This is how this disease will be gone, right? This is the disease because of dirty environment that can happen, right? You can also use what? Ivermectin over here also. This ivermectin is going to do what? Paralyze this particular thing and kill, right? So this is the combination you can use. In pediculosis, you will be having this pediculosis in children, and you will be having this pruritic pediculosis on the head, right? These are the head louse that we are having. This is going to cause what? Pediculosis on the head, right? Head louse is going to be pediculosis capitis. Then we have got pediculosis corporis, which is a body louse. Corporis matlab body. This is also known as vagabond disease. Those people who are living outside, dirty people, they will be having this particular thing. And if you have this pediculosis on the like pubis, this is known as crab louse, and the most characteristic lesion that you will be having is known as macula seriola. Macula seriola, right? This is the most characteristic lesion that we are having. How you are going to treat this situation? You are going to give again the same drug. What is the same drug? 1% permethrin, right? This is what you are going to give along with the ivermectin over here, right beta? The next thing we are having is the viral infections. And ugly infections are going to be your viral infections. What are the viral infections we are having? These are going to be your molluscum contagiosum. We have got molluscum contagiosum, which is a soft pearly white umbilicated nodule. This is a soft pearly white umbilicated nodule. There will be a dip on the center. There will be a dip on the center, right? It is coming under the pox virus. It is a DNA virus. Yes, it is a DNA virus. DNA viruses are happy viruses, we have discussed, right? Inclusion bodies you will be finding are going to be your Henderson-Peterson bodies. These are going to be your intracytoplasmic eosinophilic bodies. intracytoplasmic eosinophilic bodies that you will be finding, and it is going to be associated with pseudo cobnerization beta. Cobnerization नहीं मिलेगा, pseudo cobnerization मिलेगा. Treatment will be, it can be self-resolving if your immunity is coming back. If it is not, you can use what, TCA, you can use what, podophylotoxin, you can use imiquimod, you can use cryotherapy also. Then we have got HPV, human papilloma virus beta. It is also papilloma virus is also a DNA virus, right? So it is going to cause what, warts. What is the mnemonic that we have remembered every time? This is going to be DSP, come eat a burger. Come eat a burger, right? Come eat a burger. This is going to be, first is going to cause deep warts, second is going to cause what, superficial wart, third is plan warts, common warts, epidermodysplasia verruciformis, anogenital warts, Boucher's wart. How you are going to treat them? You can use salicylic acid, you can do electric cautery, you can remove them with the cryotherapy. Okay, this epidermodysplasia verruciformis is known as treatment. And this 16 and 18 are going to cause what beta? This is going to cause CA cervix, है ना? इनके लिए we have got vaccination, like we have got Cervarix, we have got Gardasil, right? We have got Cervarix, we have got Gardasil, and we have also got nonavalent Gardasil. Okay, we have got Cervarix, we have got Gardasil and nonavalent Gardasil. The next one is going to be human herpes virus. Next one we have got is HHV. Remember, first one was pox virus. That was your molluscum contagiosum, was your pox virus. This is your DNA virus, papilloma virus, HPV. Now we are discussing is human herpes virus, HHV. It is also a DNA virus beta. You can have what? You can have herpes labialis, you can have grouped vesicle around the lips, cold blister will be there, fever will be there. Treatment will be acyclovir 400 milligram TDS into 7 days. Right, the same treatment will be doubled in the cases of shingles. In the shingles, the treatment will be what? 800 milligram 5 times a day and 7 days. This is going to be in the shingles, right? Shingles, you will be finding acantholytic cells. This is due to HHV3. Herpes means grouped vesicle, zoster means along a nerve segment. So you can appreciate there are multiple grouped vesicle along a nerve segment. This is going to be what? Herpes zoster. HHV3 is going to cause what? Varicella, also known as chicken pox, where you will be having this pleomorphic lesions, multiple morphology lesions on the body, and you will be having a specific dew drop on rose petal appearance will be there. Right, patient will be having fever, can be there in the child, you will be having rashes on the body, right? Instead of giving acyclovir, you can also use valacyclovir 1 gram 3 times a day into 7 days, right? You can also have allodynia, that means pain will be there with a non-painful stimuli. Then we have got what? Kaposi sarcoma, which is a vascular hemangioma. You can appreciate this type of tumor will be there. This is due to HHV8, human herpes virus 8. This is a purple plague, immunocompromised patients are common. Vascular hemangioma, right? Patient who are already having AIDS or patient who are already having TB or some kind of cancers, they are at a more risk of this particular one. HHV5 is also known as cytomegalovirus, going to show you owl eye inclusion bodies. Treatment will be ganciclovir. For all the family, you give acyclovir. For this particular one, you give ganciclovir. Then we have got at hand, foot, mouth disease. This is going to be Coxsackie AE16 and enterovirus 71, where you will be having this vascular lesions on the palm, soles and buttock and oral cavity. This type of lesions will be present on palm, sole, oral cavity and buttock. Then we have got oral hairy leukoplakia beta. Oral hairy leukoplakia, where you will be having this type of corrugated appearance. Can you appreciate this type of corrugated appearance over there? This is something you will be finding generally in the HIV positive patient with white corrugated plaque. Okay, this is going to be cancerous thing, oral hairy leukoplakia, right? This is going to be cancerous thing. What about this parvo B19? It is also a DNA virus beta. Parvo B19 is also a DNA virus. It is going to cause what? Erythema infectiosum, right? Slab cheek appearance will be there. Bilateral slab cheek appearance will be there. This is known as erythema infectiosum. Malar rash on the face, reticular rash present on the body, right? Then let's take a small break. Let's take a small break and then we will continue from here onwards, right?